I'll give them another minute since it's 2:59 to join. Then we can start. Okay, it's 3 on the dot. And I think we can start on the webinar. Good morning, good afternoon, and good evening, depending on where you are. If you have not already done so, please introduce yourself by typing your name and organization into the chat. My name is Chilunga, and I am a Senior Immunization Data Advisor for the Momentum Routine Immunization and Transformation and Equity Project. I'm based out in Lusaka, and I'm pleased to introduce to you today's webinar on targeted assessments to identify zero-dose and under-immunized children. I'll just go through basic housekeeping and review the Zoom environment for this webinar. Today's webinar is available in English and French. We are offering simultaneous translation services in French. You can access the French-speaking channel by clicking on the interpretation icon. You can see something looks like a globe at the bottom. And you can choose the language of your choice. You may use the chat feature to introduce yourself, as I said before, but please do not use the chat to ask questions. Instead, please use the Q&A button. You see it at the bottom of your screen, located on the bottom bar of your Zoom window, to ask questions or request technical help. We will collect all your questions for our speakers to answer, and we'll save them for the discussion period following the presentations. The webinar is being recorded, and following today's event, you will receive an email with a link to the recording. If there are questions that we do not manage to answer by the end of the session, we will forward them to the presenters and share responses by email. Right, so we come to our excellent speakers. Maybe you can move the slides along, or is it just for me that it started? Again, because I've discovered that, I've already covered that, yes. I want the beautiful faces of, yeah, that's it. We have 4 excellent speakers today. The first to be Jessica Scherer, who is our monitoring and evaluation and learning lead for MRIGHT, and she will give us some background on targeted assessments and surveys and introduce to us a useful decision tree. Next online will be Dr. Anna Maurice, who will share experiences with rapid coverage monitoring. Anna is a medical epidemiologist and a pediatrician who has worked for both WHO and PAHO. And then we'll be joined by Dr. Shehu Sambo, who is the director of the Primary Healthcare Development Agency in Jigawa State, Nigeria, where he is in charge of all the state's immunization, reproductive health, and nutrition services. Right at the end, but not least, I will have a very able discussant, Sarah Wanyoike, who is the Vaccine Preventable Disease Team Lead for WHO IST in Eastern and Southern Africa. She will actually discuss, have the discussion link the assessments to the WHO's the big catch-up. So that should be quite interesting for all of us because we all want to catch up. And so we will, we will listen to her at the end of the major presentations. Now, to kick us off, I'll introduce the Momentum Routine Immunization Transformation and Equity Project, the Zero Dose Children's Kit, and the Learning Exchange Series. Then I'll turn it over to Jessica and our guest speakers to present on the targeted assessments and share their experiences. We'll have about 15 minutes at the end of the webinar to answer your questions. Our speakers will be available during the Q&A, so be sure to share your questions in the Q&A box, not in the chat box, please. So our project, the MRIGHT, actually I can't see this very well. Yeah, the Momentum Routine Immunization Transformation and Equity Project. Our vision is really that all people who are eligible for immunization, from infancy throughout the life course, and especially the underserved, the marginalized, and the vulnerable populations, that these people are regularly reached with high-quality vaccination services and use them to protect their children and themselves against vaccine-preventable diseases. That is where we want to get to. Can I have the next slide? The toolkit itself and the learning exchanges, the next slide. The purpose of the toolkit in the first place is to have, to meet the need for a one-stop shop of resources to identify, reach, monitor, measure, and advocate for zero-dose and under-immunized children. We know that there are many tools and guidance and documents out there, and this toolkit aims to pull them together in a user-friendly way. The toolkit is linked and complementary to already available manuals and guidelines. So it is not being developed in a vacuum. It's linked to what already exists on the ground. Next slide. This toolkit is in draft form and we are refining it. And our method to refining it, our approach to refining it is three-pronged. That has three components. One is we have a design collaborative, which has engaged 5 to 10 countries to provide input into the design and the content and the structure of this toolkit, what it should be like and how should the different personas be addressed and so on. We have collected some primary data and we're at the stage where we want to start actually redrafting it. Secondly, we have had a field test in Nigeria. We've conducted some interviews and we've actually tried to use out the toolkit and get feedback that way, get user feedback. And then thirdly, are these learning exchanges like the one you're attending right now. Here we have different topics. Those of you who've been attending will be aware that we change these, but all of them are related to zero-dose and under-immunized children. The goal being that we get user feedback and experiences to inform the toolkit, that will build up demand, we increase knowledge and skills for the methods and approaches that are outlined in the toolkit. So that is how we are approaching the refining of the toolkit. Next slide. Okay, so today's topic is targeted assessment methods to identify, reach, and monitor zero-dose and under-immunized children. And at this point, I want to hand over to Jessica, who will take us through the introductory slides. Jessica?
Thank you, Chilunga, and thank you so much for everyone who's been able to join us today. As Chilunga mentioned, today's topic are targeted assessments and surveys. These are a module in the toolkit because as we aim to identify, reach, monitor zero-dose children, sometimes we don't have the administrative data or the existing information to know exactly where these children live, why they are zero-dose, how many there are, etc. And as Chilunga mentioned, the toolkit covers a range of topics. In our previous webinars, we have covered triangulation methods using existing data. We have also covered using health information systems to identify and monitor zero-dose children. But today we will talk about these situations where, again, you may not have that data and you have to either do a rapid convenience monitoring assessment or a targeted survey. Next slide, please. So what are targeted assessments and surveys? These are assessments where the study population is a targeted subset of everyone who should receive vaccination services and used to identify, monitor, and reach these populations. We know that most zero-dose children live in a few different settings, so conflict settings, urban areas, other settings where they sometimes do tend to be a subset of a larger population, and we don't necessarily have the information in that specific context or for a specific subpopulation that we need to design and tailor services. So targeted assessments and surveys can use non-probabilistic sampling approaches, such as rapid convenience monitoring. They can also use probabilistic sampling approaches, and we'll cover some of those as this webinar continues. And the choice of approach, and again, we'll get through this today, depends on your information needs as decision makers, as managers in health systems, or as healthcare workers. We also note here that serology surveys are an option. In some of the settings where zero-dose children live, particularly conflict settings or settings of rapid urbanization, vaccine cards may not be available during surveys, and more often we're seeing sero surveys being used in these cases. A big reminder is that with any of these assessments or surveys, we're not only trying to understand whether children are vaccinated, but why or why not they are vaccinated. And so we recommend here linking to other questionnaires to understand the drivers and root causes of under-immunization. Those include the behavioral and social drivers questionnaires and the WHO Harmonized Health Facility Assessment. So if resources permit, you can combine a targeted assessment or survey with a health facility assessment to understand the extent to which the health systems and health services are ready and of appropriate quality to provide immunization services. And finally, any targeted assessment should enable immunization programs to design, implement, and evaluate interventions. And you'll hear some really wonderful examples of that today. Next slide, please. So, as we mentioned, the first step in understanding if a targeted assessment or survey is needed is understanding whether you might have the information you need to identify or monitor or reach zero-dose children without extra data collection. If you have high-quality, fit-for-purpose existing information, you don't need to go through this extra step, potentially. But if those data are missing or lacking, and you feel that there are gaps to fill in terms of information, the toolkit that we are preparing helps walk you through those decisions and those criteria, and then helps identify different approaches that you could take to do a targeted assessment. And most of those approaches are based on what information do you need to take programmatic action. So thinking through what decisions would you want to make at the level where you're working, and accordingly, what type of data and evidence do you need to make those decisions? We're going to go to a table on the next slide, which also shows the difference between probabilistic and non-probabilistic designs. But essentially, if you have a need to estimate vaccine coverage, you probably need to implement a probabilistic targeted survey. And so you can see the list of those designs here. And we'll hear a great example of the use of LQAS from Nigeria later on. If you don't need to estimate vaccination coverage, but you do want to quickly know which children are not vaccinated and then quickly reach them, you can use rapid convenience monitoring. And we'll also hear about that example today from Anna. And just to note that in this table here, what we're trying to really, again, reinforce is what is the level at which you want to make any type of inference or want any type of information to make a decision on how to reach children with vaccines. And so that's how this table is organized, helping to think through, should it be a probabilistic design or not? And then thinking through at what level do you need information? Next slide, please. So now we are going to walk through two hypothetical use cases for a bit of fun. So I'm going to read these aloud, and people will use the chat function to put in the chat which of the targeted assessment or survey approaches these two stakeholders might use. So there's no right or wrong answer really, but thinking through the very brief overview that I've provided, please put in the chat which survey or assessment approach you think might be applicable. So the first example, she's a manager of a health facility in peri-urban Santiago, Chile. One neighborhood in her area has experienced rapid population migration, and she suspects there are many zero-dose and under-immunized children who have not yet been linked with health services. Her team is ready to speak with them and bring vaccines and other services to this community. So what assessment approach should she use? So if you recall from the table that we just went over, I know it was quick, but see if you can put in the chat any ideas of what assessment approach might be used for example 1. It's a very local need for information. So let's see if anyone has ideas, and we have some responses in there. Great. Okay, and we have LQAS is coming in, rapid convenience monitoring, a rapid assessment and survey. Great suggestions. Feel free to continue putting in your ideas there. I'm now going to read example 2, which is a bit different. So in example 2, you are the EPI focal point for a large state in Nigeria. Some of your LGAs, local government authorities, have weak administrative data. So it's not data that is very useful for you to understand or have a good sense of the prevalence of zero-dose children or the root causes. More accurate information are needed for estimating coverage and planning tailored solutions. In this case, what assessment approach would you use? And for the second case, we have some hints such as estimating coverage, the prevalence of zero dose is unknown. So these are hints that this decision maker would like a probabilistic approach so that he can make those estimations. And so we have LQAS, which is one of the probabilistic approaches proposed. Yeah, or probability proportion-based sampling. Great. So we just wanted to give a bit of a flavor for the types of decisions, the types of trade-offs that people might be making when you're thinking about targeted assessments and surveys for identifying, monitoring, and reaching zero-dose children. We're going to hear some excellent examples later today. Prisa, if you go to the next slide, I think next we have a poll question for the audience. So Chilunga, over to you for the poll question. Chilunga, I think you're muted, but I'll just remind people that you should see a poll question in front of you.
Sorry, I was muted. Yes.
Go ahead.
Yeah, you should be able to see a poll question that you need to answer. Basically, you have to select one of 4 options, and it's a multiple choice. Katie, how is this going to? Are you going to give them?
Let's give about 30 more seconds and then we'll end the poll and I'll share the results.
All right. Right, there we are. Most of you said 69% rapid convenience monitoring, 55% household surveys using probability proportionate, and then lot quality assurance came in at 41, and AP30 cluster survey came in at 17%. So these are the approaches that you use in the setting where you work. Okay, great. Thank you for informing us. We'll move on to the next presenter. Anna?
Yes. Can you hear me? Good day, everyone. My name is Anna Morise, and I'm going to talk about rapid coverage monitoring. I'm happy to see that many of you have experience on doing this. but I'm going to share the experience in the region of the Americas. And the first slide is about what is rapid coverage monitoring. In the Americas, it is a recommended method. It was recommended by the Technical Advisory Group of Preventable Diseases, the Vaccine Preventable Diseases. And they recommended this method because it's a method that rapidly can assess the coverage, and also not only to assess, but also to guide the local vaccination activities. It is a simple and low-cost tool that quickly assesses the percentage of people vaccinated, but also provides additional information about the reasons why, about the whys. It is conducted by the local team and supported by subnational and national teams. But in some countries, they use a way, they call it cross monitoring, so that one district go to another district, so they exchange the experience, and also it works like an external assessment. It is a supervision tool. And in the Americas, it has been reported as a good practice to assess not only the coverage, but also the program performance, and also to increase in the mid and long term the access to vaccination services. We published this toolbox, and this is the link. We can share it after the webinar. And module 3 talks about rapid coverage monitoring, so you can review if you want to know more information about it. The next one. But also it's important to know what is not rapid coverage monitoring. And the first thing is that it is not a probabilistic survey, because it is not based on statistical sampling, and it does not weigh the results. So it's basically the information of the local area that the field teams is assessing. So the data obtained by RCM are not representative of the area, and that's important to take into consideration. And it should not be aggregated to calculate coverage in the localities, just the specific area that you are assessing. So it does not allow to draw inferences from the data of the population. It's just to make local decisions in a very small area. The next one. We have been using RCM for different purposes. In the routine immunization vaccination services, also as a supervision tool. I'm going to share with you some experience about after the outbreaks or during the outbreaks to reach unvaccinated people, and also to assess risk areas where the virus can be circulating, but also during campaigns and after the campaigns. And in this moment, the big catch-up is also a good opportunity to use rapid coverage monitoring because it's a rapid tool and it provides very helpful information for making decisions at local level. And we select the areas based on different criteria. In the routine, usually they select the areas based on risk criteria, but also randomly. But it is important to note that randomly that not implies that it's a probabilistic sampling. It's just a way about how to select the areas in case you don't have a risk area already selected. During supervision, the supervisor also select based on risk areas, but also randomly. It can be, that's another way. And of course, in case of outbreaks, the areas are selected to detect new cases and also to assess if the people around the places where the virus are circulating are already vaccinated. And who is responsible? That's another key question. Usually the local health unit, but also it can be done by the outbreak response team in case of an outbreak. And also during campaigns or catch-up vaccination, as the purpose is to verify if the vaccine coverage was achieved, it is implemented by the subnational or the support, with the support of the subnational staff. Or as I mentioned before, it can be conducted by teams working in other areas. The next one. And in this moment, after the pandemic, RCM can also be used to identify and reach zero dose, and also to conduct or to guide catch-up in under-immunized communities, because it facilitates how to search the vaccinated people, and it identifies the reason why the children or the people are not vaccinated, but also it provides an opportunity to clarify misconceptions and to guide the communication strategies if it is necessary. It is important for the field teams to go to the field and talk with the people in their households. So it provides very helpful information at the local level. But also it is a tool that is helpful to assess the quality of vaccination records. Both vaccination cards, if the population, they have the cards, because this is an important tool to review if they are vaccinated or not, but also to assess the vaccination registries in the health unit. So we have been using RCM as a tool when we conduct data quality assessments. It provides information to support decision-making, to whether target interventions. That's why this is one of the tools included in the toolbox, because this is a targeted assessment. But I think this is a very important one. It promotes better EPI program performance at the local level, because it provides information in the reality of the communities. The next one. I mentioned that I wanted to talk about how and how to select the areas and how many RCMs should we conduct. Well, it depends again. The selection criteria of areas considers risk factors, as I mentioned before, and some of these risk factors are contextual, depending on the community. It could be tourism in some areas, or migration, or population that are facing barriers in access to services, or indigenous population, or in urban areas. So it depends on the local context. Once those areas are selected based on those criteria, some of the other areas can be selected randomly. But again, it doesn't mean that it's a probabilistic sampling. And it's just to assess the information at that specific local area. The number of RCM, I'm going to show you an example in the next slide, is assigned by the subnational level based on the size of the target population. And usually 20 children are evaluated in each RCM. The next one. Another important thing about RCM is that the form is a very simple form. It's just a table. And in addition to assessing if that child is or not vaccinated, we ask about the reasons why the child was not vaccinated. And in that case, there are simple questions like these ones. We ask questions about the reasons related to the population, the knowledge, the attitudes, the practices about vaccination. And it's important to adjust, to tailor those questions to the local level. Here are some examples. I don't think it is necessary, or it is against my religion. So these questions should be adjusted to the local context. But also it could be reasons related to the health workers, to the knowledge, attitudes, and practices. Like this one that is very common. The health worker told me not to vaccinate my child because he or she was sick. So this could be a question to add in the form. Or reasons attributable to the immunization service. The service is too far, there were no vaccine or supplies. So these are just examples, and we change these questions considering the local situation. The next one. This is an example of RCM used after a measles outbreak. Here we have Puerto Ayacucho. This is an area located in the Amazonas in Venezuela. So the subnational level, they segmented this Puerto Ayacucho in different areas, and they assigned the number of RCM to each one of these areas, 2, 3, 4, 2, 4, depending on the size of the population, and also depending on the risk of the outbreak. The next one. And this is another example of a very different country. This is RCM implemented after a campaign again, but after a routine a program campaign in Chile. Chile is has a very mature immunization program and a great immunization electronic registry. So it's a country with high coverage and very good quality of the information about vaccines. But even in this context, RCM is helpful. In this case, they carry tablets because they have an electronic information system to verify the vaccination status in the field, in their households. But also the field teams, they take vaccine and supplies. In case they find any unvaccinated children, they vaccinate the children, the children or the child, they find one of unvaccinated child. And also they use this kind of notes to left in the household in case they need to send a message of they need to revisit the health center. The next one. And this is how we do the interpretation of the results. After we visit the household, we collect the information. If the community is well vaccinated, more than 95%, that's the cutoff value that we use. So we use a check. Well, this community is well vaccinated. And if it is below the threshold level or the expected coverage, we vaccinate the unvaccinated and we decide an intervention strategy. And also, if the coverage level is low, they need to repeat the RCM. The next one. So, and I think this is the last. This is a helpful tool because it is used for making decisions immediately after they finish the RCM. And here are some of the questions. So the field team asks if the results are showing that the children are vaccinated. It's also important to compare the RCM with the administrative coverage at the health facility. If the coverage levels were not achieved, what are the possible explanations? What did the parents or caregivers state for the target population not being vaccinated? Are there other unvaccinated population located close that we need to go? What would be the most effective tactic to reach them unvaccinated? And finally, what actions should we take? Marisa? Okay. Thank you so much.
Thank you so much. That was great. We'll go into the next presentation from Nigeria, LQAS. I noticed most of you hit the LQAS as one of the things you do. I think it came second top, towards the top. So I'll just invite Dr. Sambo to lead us through their experience of using LQAS in Nigeria. Dr. Sambo?
Okay, good day to everyone. And my name is Dr. Shehu Sambo, Director of Primary Healthcare, Jigawa State, Nigeria. So this is the outline of the presentation. I'm going to talk more on LQAS as well as other assessment tools that we have in the state to reach out to zero-dose and unvaccinated children. Introduction, Jigawa State efforts in zero-dose reduction, rationale for selecting the survey design, planning and implementation, analysis, result, recommendation. Next slide. So Nigeria as a country has made commitment to reduce the zero-dose children by 30% in the next 2 years, that is by 2025. We have 100 priority local governments selected across 18 high-burden zero-dose states. You can look at the map of Nigeria on your left-hand side. You can see that most of the zero-dose children or the LGAs that have zero-dose children are located in northern part of the country, where my state, Jigawa State, belongs. So Nigeria developed a strategy called the Strategy for Immunization and PSC Strengthening NSI PSS 2.0, which has in its components sustainable financing, data management and innovation, human resource and institutional capacity, leadership management and capacity, as well as the effort to have one team, one budget, and one plan approach, which is a concerted effort for us to have a donor coordination, mechanism, so as to have synergy in terms of tackling, the problem of zero-dose children in Nigeria. Next slide, please. So this is my state. Jigawa State is one of the northern states of Nigeria. It has a border with Niger Republic. The population of Jigawa State is a little over 7 million children. It is an MRIGHT state, that is the Momentum Routine Immunization Transformation and Equity is supporting us in the state. If you look at the breakdown of the local governments, I mean, the population, you have migrant population accounting for like 18% of the population. There are areas where we have block rejection, settlements, seasonal flooding, there are international markets. And then you look at the hard-to-reach areas, those are settlements which are very difficult to actually reach, 18% of that. So according to our numbers, the zero-dose children in the state account, the number up to 15,129. And if you look at the proportion of under 1 children, that is the target for routine immunization from the whole population of the state, is 4%, which is close to 300,000 children. Then each year we are expecting 5% of the women to be pregnant, which is also over 300,000. During COVID, Jigawa State did very well because we had 100% coverage of our targeted population, which is around 3.7 million children. You can look at from the last multiple indicator cluster survey of which focuses more on immunization. The birth dose for hepatitis 0 is 60% according to that survey. Penta-3 coverage is 49%. Measles 1 coverage 56%. So we have a lot of work to do. We had diphtheria outbreak in some local governments. There are issues with the measles, pertussis, CSM. These are all vaccine preventable diseases, which shows that we haven't covered the population. There are a lot of work to do. As I mentioned, there are international borders. Then if you take the rural LGAs, we have 27 LGAs, local government areas. The rural local governments account for 90% of that. There are interstate borders in 17 local governments. And the vehicle for delivering immunization and primary healthcare services is the Jigawa State Primary Healthcare Development Agency. Next slide, please. Okay, so now strategies in Jigawa State for addressing the zero-dose and under-immunized children. Number one, you can see the assessment and the co-creation. First, we need to identify where are the zero-dose and under-immunized children. That is where our selection of the method comes in. We are doing the lot quality assurance sampling, as well as the lot quality assurance sampling, that's the LQAS, is driven by the National Primary Healthcare Development Agency and is conducted every quarter. While in Jigawa State, we have added what we call RIRA, that is routine immunization rapid assessment, as well as the routine immunization supportive supervision. All of these methods help us identify zero-dose children as well as under-immunized children. We then engage the communities for, to show them the gravity of the problem, where those children are located. Then we move to number 2, which is capacity building. We train our healthcare workers, we mentor them, and if there is any adaptive learning, we incorporate that into the capacity building to be ready to take the task of reaching out to those children already identified. And then the demand generation and commitment. We pay a lot of advocacy visits to communities, community gatekeepers, stakeholders in immunization, community engagement, demand generation, behavior change programming. So all that is into the demand generation activity. So we move to service delivery. You know, you start with updating your micro plans, making sure that you incorporate every child, every settlement, so that you cannot miss anyone. Then you start with targeted outreach services, optimize your fixed sessions. Then you follow up that with routine immunization, supportive supervision. You also integrate all of that with any program going on, be it polio campaign, be it nutrition program, antenatal services with the, you know, women. Some of the women come with the children. So that's where the integration comes in. And then finally, we monitor what happens, monitoring and supervision, review meetings, data quality assessments. A lot of the data is, the quality is much to be desired. So we do a lot of that. So that is the whole strategy as a state, where we feel that all things on deck, hands on deck, will be able to reach out to all the zero-dose children. Next slide. Okay, so now service delivery. I think we have said that supportive supervision. We triangulate demand, service, and commodity data, community mapping, and outreach planning. Then provider behavior change. A lot of some respondents, caregivers, parents, mothers, tell us that it's the behavior of the caregiver that's making them not to come. So we are also working on that. So monitoring, community and social listening, feedback loops. We give a lot of feedbacks, especially to our traditional religious leaders. We collect data, analyze, and manage rumors, myths, and misconceptions around immunization. We also report the adverse effects following immunization, because some of that also prevent
oh, we seem to have lost Dr. Sambo. Okay.
Okay.
Carry on.
Okay. So you can see in March, we reached out to March 2023, 7% of the zero-dose children, and then April 12%, June 2023, 8%. Cumulatively, we reached 27% of the children, which are close to 30,000. So if we go by these numbers, Jigawa State is going to come out of the states with zero-dose children by the year 2023. Nigeria is targeting 30%. Jigawa State is targeting getting out of states with zero-dose. So next slide, please. Next slide. Okay, good. So this is the lot quality assurance sampling table for Jigawa State. We started this activity way back in Q4 of 2017. As I said, Jigawa State has 27 local government areas. You can see them on your left-hand side of the screen, their names. So you can see the first LPAS that was conducted, the sampling that was conducted, you know, we had no local government area in green. So all of these local governments, the lots were not accepted, so they failed the lot. Coming to the next quarter, let me say that the LPAS is conducted every quarter, every 3 months, so 4 times in a year. So you can see Q1 2018, we started having a green local government, which is Garki in that in that quarter. Q2, we had 2 local governments. Q3, and we started moving. We reached our peak in Q3 2019, where we only had a yellow LGA in that quarter, which was Buri. The yellow LGA means that for you to be green, you need to have 8 or less than, or less children sampled that were not vaccinated out of 60 children. So that's that's the guideline. So quarter 3 2019 to quarter 1 and 2 and 3 2020, something big happened to the global community, which is the outbreak of COVID-19, and that hugely affected the immunization services. We were able to come back to do the LQAS sampling. In quarter 4 of 2020, you can see the results. Actually, a lot of local governments were in yellow, and we moved on to 2021, where now we are trying to pick up the pieces. More green LGAs are coming out. So that is the picture for Jigawa State when the lot quality assurance sampling was started. And we give feedback to all the LGA team members for immunization every quarter. After every result is shared, we come together, we look at the results, we map out strategy, mitigation plans, and all that is needed, community engagement, everything will be put in place for us to reach out to those children that cause the local government to be in yellow or in red, but those that are in green are rewarded and then told to do more to maintain their status. Next slide. Okay, let's move to next slide. So you can see if we embed the RCM in supervision, which is the routine immunization, supportive supervision, community survey, like from October this year to, from January to October this year, we were able to sample 65,000 children, 650. Out of that, fully immunized accounted for 55,138, partially immunized 5,303, not immunized, those are the 0-dose children, 1,173. So you can see this is a routine immunization supportive supervision. It's not the LQAS I presented. So all the unvaccinated children and partially vaccinated were reached out with antigens and linked up with service subsequently. That is the advantage of the risk over the LQAS. LQAS, you later go and find out the children. This one, you immunize them there and then. When you reach any partially immunized child, you update his immunization status, you call on the super immunization service provider covering that locality using the micro plan they have. All the real micro plans, were reviewed. 100 of them, 100 health facilities were supported. 4 of the real micro plans reviewed incorporated and identified settlements and population. You can imagine a whole settlement or a population missed. So that's the importance of this risk survey. To next slide. Okay, so on the rationale for selection of these methods, the other method I think is RIRA, as I said, rapid routine immunization, rapid assessment. So these are already, we funded activities. They are into the state plans, the routine immunization supportive supervision and the RIRA. They have existing tools already. The personnel are trained to conduct the assessment using them. So the lessons that were learned from planning and implementing the risk community survey are, in particular, one, as I said, tools already exist for community survey to identify and reach 0-dose children, and they are cheaper to deploy and more sustainable. Healthcare providers have been trained on deploying these tools. This approach enhances linkage between health facility and the community. the state actually developed this into the plan as a response to what we get out of the lot quality assurance sampling that comes out every quarter, where this supportive supervision happens every week. RERA 2 happens every 2 or 3 months in the state, depending on the plan. So recommendations now is thinking that we need to sample more children, more than the 10. Because of time, I didn't tell you the methodology, how to select, how to select the number of settlements and all of that. So we want the selection to be from 10 to 30, more children to be sampled. Then timely release of back-end data for decision and action. This concerns the nationally driven lot quality assurance. The LQAS is a probabilistic approach of sampling that we do, as it was highlighted before. So improve monitoring and mentoring on the conduct of the routine immunization supportive supervision. And then more accountability measures need to be put in place for us to do better as a country and as a state. So I think
thank you.
The last slide, if I'm not. So thank you very much for listening. Thank you.
Thank you, Dr. Sambo, and you've got interesting questions that we'll discuss afterwards. Before I turn it over to Sarah for her perspective on how all this ties in, you see 4 questions there. There are a couple of them, and yeah, they relate to approaches and use cases. Could you answer those? Katie, how long do they have?
Since we're short on time, let's do about 30 seconds. And just to note, there's 2 questions for folks to answer.
Okay, there you go. 30 seconds, half a minute. Right. So which approaches would you want to learn more about? TOPS is rapid convenience monitoring. And then there's household surveys, but almost the tie is LQAS and AP30 cluster. So our biggest need, according to this, is rapid convenience monitoring. What use cases do you have for a targeted assessment where you work? Well, TOPS there is to identify specifically who they are and where they live. Yeah, well, it's true. That makes sense. And then following on that is to tailor interventions and then identify the prevalence and then to inform catch-up and recovery strategies. So with that, I'll move on to Sarah. Sarah, can you do 5 minutes because we're really short of time?
Oh, yes. I am from Kenya. We run marathons. Yeah, I can do even less. Yes, thank you very much, Chilunga and facilitators. Thank you very much to the presenters also. I think this has been a very useful and insightful session. Very good to learn about the different experiences from the countries with the rapid convenient surveys as well as the LQAS. I think in terms of reflecting, I think maybe mine is a question I didn't put there, but I think one of the issues I'd like to bring for consideration is costing of how much these surveys cost to do, because I think that's a question most of our countries are asking right now. Another thing to think about is, as we're doing all these catch-up activities and there's different partners on the ground doing catch-up activities, how do we ascertain that we are, because we in the big catch-up that we're doing, there's recovering, coming back to 2019 numbers, but then also there's restoration, which now also goes into building now sustainable health services. So it's about resilience. So there's phases into it. So I just wonder how all these numbers, as we're monitoring, as we're thinking about it, at what point have we recovered? At what point have we restored our programs? At what point do we now start re-engaging a little bit and shifting gears to talk about sustainable programming? So maybe just reflect on a meeting we had here in Brazzaville with the Regional Technical Advisory Group, and these are discussions we've had extensively. One thing we have talked about, a lot of investment has gone into identifying zero-dose children, zero-dose communities. And I appreciate some of the presentations are actually asking the why. Why are they zero-dose in the first place, so that we can actually address and modify as we go. The issue with this here is it really a one-off activity to do catch-up activities, or is it something that should be built into annual program planning? My screen.
Hi, have you dropped or have you finished? Okay, okay. Are you back?
No, this is Jessica. It sounds like she maybe dropped, and so why don't you go ahead with some questions?
I'll go with the questions, yes. Since our discussant has unfortunately dropped, but we don't have a lot of time anyway, this brings us to the end of our presentations. And we just spend the last few minutes to look at the questions that are in the chat. There are quite a few interesting questions, and I'll address these to the panelists that are actually left. Mohammed Diop asks, there are a significant number of zero-dose and unimmunized children among nomadic populations between Nigeria, Chad, Cameroon, and Niger. Could you please share specific and tailored strategies to vaccinate them? Is there any collaboration between the countries? Maybe I'll address this to our Nigerian colleague.
Okay. Dr. Sambo is speaking.
Yes, sir.
Yeah, what we do, you know, the nomadic population actually crisscross countries, you know, looking for greener pastures for their cattle, goats, and sheep. So usually we have cross-border meetings, but those concern mostly campaigns generally, not on routine basis. Because like in Nigeria, a lot of the countries in our borders speak French. And our card, child health card, which contains the immunization data of the child, is in English. So I think here is a great question, telling us that there is more to be done in collaborating between the countries, because this nomadic population crisscross the countries. They don't have any border, international border. Now we need to sit down and harmonize our child health cards, so that when they cross into Niger Republic or Chad, they'll be able to read what we have done, and they carry on from there. When they are coming back, we should look at the cards and see, okay, which immunizations are pending for the children, and update that. So by the time they are going back, the child could be fully immunized. In Jigawa State, as I said, there is a border from Niger, and they crisscross down to Cameroon. As he said, Mohammed is right there, and into Chad. So we need to do more there. Right now, we do our bit. We have groups, immunization teams that target nomadic population. We also have support from African Field Epidemiology Network and CDC targeting exactly nomadic population. And we incorporate those into our plans. We know their routes, where they pass, how they pass, through which LGAs, and we do catch up. We meet them, we discuss, and there are people that speak their language in Jigawa State. So we do that, but more needs to be done. Thank you. I hope somebody can add on this.
Thank you. We've only got 1 minute. Can somebody add on briefly? And while we are waiting for somebody to add on briefly, please don't forget to do your feedback. You can scan the code, the barcode at the end of the presentation, or use the link that has been provided. There was another question from Nancy Foreman, and it has been answered by Jessica, but I think just so that everybody hears it. Based on the zero dose toolkit work to date, what type or types of data collection would you recommend for more deeply understanding why children are zero dose or under-immunized in local contexts? And will such data collection guidance be included in the zero dose children toolkit? And Jessica responded, hi Nancy, the toolkit will link to existing tools for understanding why, such as the BESD questionnaire. We also hope to build out more co-creation and root cause analysis tools. Thank you so much. We are on the hour, on top of the hour. And therefore, I'd just like to thank everybody, please, for all those who have attended. Thank you for your time. For me, it has been a very exciting webinar, a lot of learning, and we hope that we'll continue the learning going forward. Please don't forget to do the evaluation. And yes, and any questions that have not been answered, we'll follow them up. And yes, we just want to thank you again. Have a good morning, day, afternoon, evening, as the case may be, wherever you are. Thank you very, very much. But please do the evaluation. Scan that barcode there and do the evaluation. Thank you so much, everybody. Thank you.